Hello, my name is Alexander Chan from University of California, Irvine. I'm a professor of clinical pharmacy, and I'm here to provide some insights on how to manage cancer patients' chemotherapy-induced nausea and vomiting. The learning objectives of this presentation include the following: to review the definitions, pathophysiology, and risk factors of chemotherapy-induced nausea and vomiting, to describe the current guidelines on managing chemotherapy-induced nausea vomiting, or CINV in short, to describe the pharmacological and non-pharmacological options for managing CINV, and to understand a pharmacist's role in managing CINV in clinical practice. So this is going to be the breakdown of today's content. We'll first talk about the background and definitions related to CINV. We'll talk about the risk factors, what are the latest guidelines and antiemetics that are being used, and to wrap up, we'll talk about pharmacists' role in this setting. It's extremely important for us to standardize the understanding of the terms associated with nausea vomiting in the context of chemotherapy. We understand that the first day of chemotherapy in the next 24 hours or so is the acute phase where nausea vomiting can occur. Anything beyond the 24 hours up to 5 days out of chemotherapy, that's the delayed phase of nausea vomiting. And breakthrough emesis can happen anytime, between day one all the way until day five out of chemotherapy. And that's what we call breakthrough chemotherapy nausea vomiting, despite the fact that patients might be already receiving prophylaxis for the acute and delayed nausea vomiting. And lastly, anticipatory nausea vomiting can occur even before patients getting chemotherapy, likely because they smell something or perhaps something with the limbic system that they pick up that somehow trigger that anticipatory nausea vomiting response. It's very difficult for us to talk about nausea vomiting without talking about the neurotransmitters that are involved. So we understand the fact that when patients receive chemotherapy, these drugs actually would affect the gastrointestinal tract by releasing different types of neurotransmitters, which include serotonin and then dopamine and also other types of neurotransmitters that actually would travel up from the vagus nerves all the way going to the midbrain. And what happened is that it would affect the chemoreceptor trigger zones. In that particular zone, there are multiple receptors, and this particular zone will actually help to stimulate the vomiting center in our midbrain, which actually would lead to a lot of the clinical responses that patients experience while having nausea vomiting, such as increased salivation, increased respiratory rate, as well as different types of muscle contractions that can occur as well. Who are the patients who are at risk for chemotherapy-induced nausea vomiting? There are a lot of studies have actually looked at the different risk factors associated with chemotherapy-induced nausea vomiting. That includes different types and doses as well as schedules of chemotherapies, and we'll talk more about that in the later part of the talk. Anxiety is a huge risk factor. Age, particularly in younger patients, and this is sort of controversial. Some studies cite lower than 30 years old, some studies have cited below 50, but generally speaking, younger patients, and keep in mind, malignancy or cancer is a disease that's more likely to happen in elderly. So certainly in younger patients, the prevalence of that is certainly lower, but they are certainly at higher risk for nausea and vomiting due to chemotherapy. Female as a gender were prone to higher risk. Low alcohol use, history of motion sickness, history of pregnancy associated emesis, as well as history of poorly controlled emesis in the prior chemotherapy treatment would also prone patient at high risk for CINV. There are quite a few international guidelines that are available for managing CINV, ranging from the American Society of Clinical Oncology, or ASCO, as well as MASC, which is Multinational Association of Supportive Care in Cancer, and ASMO, the European Society of Medical Oncology, and the NCCN guidelines, which is a National Comprehensive Cancer Network. All these different organizations have been publishing guidelines associated with CINV. They are relatively similar. There are subtle differences with these guidelines, such as how they classify the immunogenicity of certain drugs, and some recommendations can be different. So, it might be useful for you to compare and contrast some of the differences that you see in these guidelines. What I'm actually very proud of in terms of the science behind CINV is that, over the last 60 years or so, we've learned so much and understand so much about the science of CINV. We see the number and the types of antiemetics that are made available over the years have dramatically increased as well as improved. We have gone from drugs that we are not very specific targeting many different types of neurotransmitters, moving into settings where we are targeting specific neurotransmitters such as the 5-HT3 antagonist, and then moving into drugs that are targeting substance P or the NK1 receptor antagonist, as well as combination pills, so that will help to reduce the pill burden for patients undergoing chemotherapy-induced chemotherapy. If you look at the guidelines, there are very specific recommendations on how to prevent nausea, vomiting by using appropriate antiemetics. And if you look at these slides, I've got two slides here that looked at how to prophylact patients who are getting intravenous anti-cancer therapies, as well as the use of antiemetics to prevent nausea, vomiting in patients getting oral anti-cancer therapy. You'll notice that they are classified based on the risk of patients getting nausea, vomiting based on the regimens, the chemotherapy regimens who risk for having nausea, vomiting, as well as the different phases that we have talked about earlier on when nausea, vomiting can occur. And based on the different phases, different prophylactic regimens are being given. And you can see that they are very likely to be combination antiemetics that are being given to these patients as part of that prophylactic regimen. Besides using antiemetics, there's an important role to play in terms of providing important and essential patient education information to ensure the fact that patients understand how to control their diets, as well as, ensuring the fact that, when they're experiencing nausea, vomiting, what are the things they can do to reduce the complications from these nausea, vomiting. Dietary related sort of advice include: one, eat small, frequent meals versus eating larger meals, which can make patients become very nauseated. And certainly only advise patients to eat large meals when they are least nauseated so that, the meals do not trigger the nausea, vomiting. There's also a lot of mixed information about whether or not the patient should be avoiding their favorite foods or not, because sometimes patients actually will become more nauseous when they're eating their favorite foods. Again, a lot of patients, when they're undergoing anti-neoplastic therapies, the taste buds change. Also, patients are advised to eat room temperature food so that there's less aroma. Avoid very extreme sort of tasting foods such as too sweet, too salty, too spicy, too fatty, or foods that are too aromatic. And it's important to counsel patients not to overeat before they receive treatment, or if they are having nausea during the treatment as well. And if patients are experiencing nausea, vomiting, there are certainly a lot of different supplements, as well as, you know, um, ways to improve their nutrition intake. So they can still eat crackers, bread, continue to, encourage your patients to improve their fluid intake, drink clear fluids, fruit juices, and other types of fluid content like popsicle, jello, frozen fruit juices, or even ice chips that can help to provide sources of fluid to these patients. As a pharmacist, I'm very proud to say that managing nausea, vomiting is an important role that we play, because one thing we can do in the cancer center setting, is that we help to standardize the prescribing of a lot of these antiemetics. Pharmacists certainly plays a huge role working with multidisciplinary care team to establish guidelines and protocol sets, as well as developing institutional guidelines, and also in the process of chemotherapy checking to ensure that patients are equipped with appropriate antiemetic prophylaxis. But also pharmacists, knowing that we work very closely with patients, we also play a very important role to counsel as well as to monitor patient status while they're undergoing these treatments. So it's important to counsel patients how to use the antiemetics appropriately, the concept of prophylaxis to prevent nausea, vomiting. So as a result, it's important that our patients are adherent to the antiemetics they're being prescribed to. And of course, the importance for us as pharmacists working with the care team to monitor closely our patients' symptoms post-chemotherapy. And if patients are experiencing overt nausea, vomiting, need to be able to recommend appropriate antiemetics, as well as good documentation so that in the future cycles of treatment, we are providing additional coverage, additional prophylaxis to these patients to prevent nausea and vomiting. So in summary, excellent control of nausea vomiting is possible with appropriate usage of antiemetics, and a lot of those are guided by guidelines. Guidelines currently suggest combination use of these antiemetics, and depending on what phase that we're talking about, and I would urge you to revisit the slides that we have that talked about the appropriate prophylactic antiemetics that's being used at different phases of managing our patients' CINV. But again, allow me to emphasize pharmacists as part of the multidisciplinary care team for patients with cancer can play important roles to optimize patients' antiemetic use and by then improve patients' quality of life. Thank you.